is probably the best answer. Saline replacement is not a bad answer, although wouldn't deal with the discrepancies in both the forward and the reverse type. Saline replacement is the method where it's done really on the reverse type, where after the reverse type is done and you have the cell button, the patient's serum is removed and replaced with saline. And if the agglutination that's seen with the patient's serum persists, then you know that it's true agglutination. And if it resolves, then it suggests that it's actually more non-specific agglutination that was happening, potentially because of high protein levels or things of that nature. So that would fix the discrepancy on the back type, but not on the front type. So not as good of an answer. Adsorption elution really wouldn't have much role in helping out here because we're not necessarily thinking this is a strong autoantibody that's interfering with things. It would be a little bit more diagnostic potentially if that's the case for the elution particularly. And decreasing the incubation time wouldn't be expected to resolve the front or the back discrepancies. So the next stem of the question is that the ABO typing is repeated, and this was neglected in the answer, but after RBC washing and saline replacement. So the original stem had just saline replacement in there. And what we're seeing with the forward typing now after these two steps is that the anti-A reactivity that we're seeing before is 2+ is now 0. So no reactivity with anti-A. Anti-B is still strong at 4+, so looking like a B on the forward typing. And on reverse typing, we're seeing strong reactivity with A1 cells, fitting with the B that we're seeing on the front typing. But again, some reactivity still persisting on with the B cells in the back type. Again, this is after saline replacement, so this appears to be true agglutination and not something due to excess proteins in the plasma. So question 3 then is, which of the following is most likely to resolve this discrepancy? And in terms of the options, you can see them there. Most people had like everybody clustered around pre-warming the plasma serum, a little bit less controversial in this one. And that's the best answer here. We kind of dealing with, now that we've dealt with the question of maybe there being some excess proteins in the plasma causing some agglutination through saline replacement, and we've thoroughly washed the cells to remove any contaminating plasma that might have been there. We're still seeing this reactivity with the back type, not as much with the front type. So mostly consistent with potentially a cold autoantibody in the patient's plasma interfering with the reverse typing. So that's why that's the best answer for this question. Question 4, so which of the following red cells are not likely to help determine the specificity of the antibody causing the discrepancy? Options being cord O cells, adult O cells, adult A2 cells, or OH or Bombay cells. In terms of responses we had for this one, bit of a spread. Like most of the majority of answers clustering between A2 cells or the OH Bombay cells, and a few other answers for cord O or adult O cells. So what's the kind of concepts behind this question? Well, if we go back to the forward and reverse typing, what we think might be happening, interfering here, is we have a pretty good evidence that this patient is truly is truly a group B based on the forward typing, with the reverse typing showing this missing or extra reactivity with B cells, so some anti-B that might be there that may not be actually true. So under the assumption that this is the case, we think this is probably a cold autoantibody, which is where the pre-warming would help. And with that in mind, then we think, okay, well, what are the specificities we'd expect with cold autoantibodies? And the specificities with cold autoantibodies tend to be against carbohydrate-based groups, with some of the most common specificities being anti-big I antibodies, anti-little I antibodies, and then antibodies against the compound between both I and H. So if we look at the options we have for the answers with cord O cells, how are they going to be different from the other cells that are shown here? Is there going to be predominantly little I antigen expressing rather than big I, because the big I, as we develop, little I is expressed predominantly, and then as we get older, big I becomes a predominant I antigen expressed on the red cells. So we'd be able to differentiate little I versus big I specificity using cord cells. Adult cells would be the inverse, where they're going to have a lot of big I antigen, but not as much little I antigen. So reactivity with one or the other would give us a sense of whether it's specificity against I or H. Skip down to group to answer D, the O Bombay cells. Those are Bombay cells. The feature that they have is the patients that have that are missing the fucosal transferase that allows them to make H antigen. So patients with Bombay have no H on the outside of their cells. So that would then allow us to differentiate H specificity. And so we're left with the adult A2 cells. And so what is unique about those cells compared with these other cells? Well, the answer is really not much. So A2 cells are going to have a fair amount of big I expression because they're adult cells similar to cord O cell or to adult O cells. So you're not really getting a lot of added information between the A2 cells and the O cells. And in terms of H expression, although they're going to be a little bit reduced in H expression compared to O cells, they're not really going to be all that much reduced in H expression compared to O cells. So you're not really getting a lot of extra information with the adult O cells compared with the adult A2 cells. So the adult A2 cells are probably the best answer with this question in terms of figuring out what the specificity of the antibody might be. Question 5, so which additional laboratory tests are unlikely to provide useful clinical information? Their options being a direct antiglobulin test, thermal amplitude, or thermal range testing, depending on how your lab calls it, cold antibody titer determination, or extended phenotyping. So in terms of responses for this one, a little bit more of a spread of responses with almost equal responses for DAT and thermal range testing as being unlikely to provide useful clinical information. Fewer people are thinking that the cold antibody titer would be helpful, and then most people thinking that extended phenotyping would not be helpful. So concepts going into answering this question. So what information would we get out of these individual tests? So with the direct antiglobulin test, and again, I guess just going back to what are we seeing here is that we're seeing suspected cold autoantibody. And so if we're thinking about, what information would we want to know about the cold autoantibody? Well, if we do a DAT and the DAT is negative, well, that kind of tells us this might just be a nuisance cold autoantibody and not as much something that's relevant for the patient. Whereas if the DAT is positive, then that starts to raise concerns that actually might be more relevant clinically for the patient because we have evidence it's actually sticking to the patient's cells. So I think DAT does provide some useful clinical information. Thermal amplitude testing. So this is the testing where we look to see at what temperature does the antibody stop reacting with the test red cells. And we know clinically that the closer the antibody reacts to body temperature, so the closer it reacts to 37 degrees, can be a distinguishing feature between patients that have cold agglutinin disease, where the antibody is actually causing clinical problems, and more kind of just in vitro phenomena, antibodies that are there but not really causing any clinical sequelae. So antibodies that tend to react at lower thermal ranges, 4 degrees, 16 degrees, but not at higher temperatures, are often less clinically significant. So that does provide some meaningful information. And similarly for the cold antibody titer, higher titer antibodies tend to be more likely to be problematic clinically. So low antibody titers of 4, 8, they're not going to be as likely to cause problems as antibody titers in the 256, 512 range. So the higher the titer, knowing the titer will provide some of that information for us. So then finally, extended phenotyping. Well, what information does that provide? Well, that would give us information about the patient's antigen expression on the outside of their RBCs. But in this case, won't really provide us much useful clinical information because there isn't really going to be a lot of relevance between that and the potential of a cold antibody. Where we'd really be worried about is this cold antibody we're seeing in the reverse type, is that causing any problems for the patient? That's where D is the best answer here, which I think most people got. I'll just pause there maybe just to check in. I don't know, Tracy, if there's any questions that come up or things are quiet. I'm bad at doing multitasking, doing both, so I don't want to miss any questions that are coming up.
I don't see any questions yet, and I haven't seen anybody raise their hands yet. So just a reminder, if you do have a question, to raise your hand if you want to ask it like verbally, or you can put the question in the chat and we will make sure that Dr. Mack sees it.
Perfect. Thanks, Tracy. Right. So question 6. So we have this information now that the patient's confirmed historical ABO group we find out is group A. And so what is the most appropriate next step for this patient? So again, a reminder that I guess we'll go through the answers and go through the reminders of the rationale behind it. So a little bit of a mix here. Some people thinking that determining whether the patient's received a stem cell transplant would be most appropriate next step, requesting a new ABO sample. Obtaining a detailed transfusion history, a little bit less popular, and then repeating ABO typing on the current sample, even less popular. So concepts behind this question. So again, just a refresher, since it's been a while since we looked at the forward and reverse, is the initial forward and reverse typing showed discrepancies between the two with suspected unexpected reactivity on the forward typing against anti-A and in the reverse typing with the B cells. And once we washed and saline replaced, we saw persistent unexpected reactivity with B cells on the reverse typing and a forward typing that looked mostly consistent with group B. So the patient looks to be group B and we think probably has a cold antibody. So there's a problem here that we have historical type showing the patient being group A. So we've got a completely different blood type now in the patient. So if we go through the potential answers, I think requesting a new sample is probably the best next step. And the reason for that is if we think about, so repeating ABO typing on the current sample I don't think we've likely to have made an error on the typing. We've done 2 different forward and reverse typings already with fairly consistent results, at least in what's showing up as being positive, and some explanations for why some of the other typing had changed. So that not a very good answer. Obtaining a detailed transfusion history, again, when you think about that flow diagram I showed at the start in terms of where transfusion histories where transfusions might impact things, you might worry that that could potentially cause some problems for the reverse typing if there was some plasma transfusions, potentially the forward typing, although we would expect likely with most transfusions that would be out of group, we would see mixed field and not necessarily a complete group switch from being previously group A to all of a sudden all group B. So not a great answer there either. And then between determining if the patient has received a stem cell transplant or requesting a new ABO typing, both are pretty reasonable answers. You probably you may want to have this history, but when we look at the actual, like what we're seeing on the reverse typing, with stem cell transplant patients, a unique feature with them is that their forward typing will often change, but the reverse typing doesn't always change and often takes quite a while to change. So the chances that we would see this type of problem with the reverse typing, where we're seeing now the patient being complete group B following a stem cell transplant, would be less expected for a patient like this whose type is completely changed. And so more likely that we might have just drawn a sample from the wrong patient. So I think for that reason, the best answer would be to request a new sample and just start from fresh, make sure that we don't have the wrong blood in tube type of error. Right, so that's case 1. There's no other questions. See, there's a message about not being able to see slides on phone. I don't know, Tracy, if I don't have the IT.
Yeah,
I'm kind of with that, but
I'm working on it, trying to see what I can do to help.
Perfect. Thank you.
No worries.
Right. So for case 2 now, so changing focus a little bit. So now we have a sample that's received for a type and screen for a 33-year-old patient who is 12 weeks pregnant, and she's got a history of 2 prior pregnancies, 1 live birth, 1 spontaneous abortion, and previously typed as RHD negative. And we're now getting a typing that's as follows: forward typing showing no reactivity with anti-A, reactivity with anti-B, no reactivity with anti-B, so group O on the forward typing, strong reactivity with A1 cells and B cells on the reverse typing, so fitting with a group O, and then the anti-D typing now showing 1+ reactivity, and again, where she previously was typing as RHD negative. So question 1 is, which of the following tests should be performed? So options being weak D testing on neonate red cells at time of birth, weak D testing on maternal red cells, repeat typing with pre-warm plasma or serum, or blood film to screen for rouleau. And in terms of responses, we had most people selecting weak D testing on the maternal red cells, and a few people thinking about doing weak D testing on the neonate, and some people think about repeat typing with pre-warm plasma or screening for rouleau. In terms of kind of the concepts behind this one, it's after putting the question out there, I sort of regret it a little bit because it's going to be a little bit more controversial than maybe expected. But the kind of concept behind this one is sort of the value of doing weak D testing, which is maybe a little controversial, although I think there's enough consensus from different groups around the utility of weak D testing, particularly in prenatal patients. And I think two statements that are quite relevant, one from the NAC, which is that prenatal patients with discrepant, weak, or inconclusive serologic RHD testing should be investigated with genotyping to determine their candidacy for RHIG or what red cells from an RHD point of view to use. And Choosing Wisely Canada, the recommendation is not to perform serologic weak D testing on antenatal samples at all. And the rationale behind these two fairly strong recommendations is that the weak D, so if you have a concern about, sort of what is the true D status of a patient, if they're a variant D, could they be weak D or a partial D? The concern is if you do the weak D testing, will it answer the question that you're trying to answer? You might determine that someone is truly weak D or has a variant D, but it doesn't inform the decision that's really important, which is should they get ROGAM prophylaxis during their pregnancy, and how should they be supported from a transfusion point of view? There's different variants in terms of D variants, quite a few, and it's a very complex system. And some of the D variants are not thought to have much of a risk of RHD alloimmunization, and so can be treated truly as D positive. And some of them do have a risk of RHD alloimmunization, and so should be treated as RHD negative, even though they might be typing as RHD positive. And the weak D testing can't really help us discriminate easily between those different groups. And so that's where the RHD genotyping comes in, because that's going to give us a much more definitive answer. So that's kind of the motivation behind these statements from the NAC and the Choosing Wisely campaigns, is that genotyping is really going to give us the answer we're trying to get with that testing. So in this answer, I think the best answer is really to screen for rouleau, make sure that the D typing that we're seeing is not because of some other cause, with the understanding that genotyping should probably be done. But I think weak D testing on maternal red cells, since genotyping wasn't an option, I can understand why that was the most commonly selected answer. So opportunity just to emphasize that genotyping is the next best step if there are concerns about variant D variants in a prenatal population. So question 2, weak D testing is performed on this patient, and there's weak agglutination following the addition of anti-IgG. And so what is or are the next appropriate steps? So should this patient be reported as RHD positive, and we don't give RHIG, we commit to them being positive through the pregnancy? B, send a sample for RHD genotyping. C, report them as RHD negative, or both B and C. So in terms of responses, we had very few people saying reporting them as RHD negative only or reporting as RHD positive. So good to see. And a lot of people saying either sending for RHD genotyping or both sending for RHD genotyping and reporting as RHD negative. And should have reworded maybe the reporting as RHD negative to maybe a slightly different terminology. But I think both sending the sample for RHD genotyping, as we just covered, because there's variability that we're seeing with the patient previously being D negative and now typing D positive, although weakly, that incongruency needs to be resolved with genotyping to best inform what the practice should be for ROGAM and for transfusion support. Reporting as RHD negative, I guess we should probably treat the patient as being RHD negative until we know otherwise. So that was sort of the motivation or the intent behind that answer, not so much as reporting them out as formally RHD negative. So I think B is the best answer with the wording of C, but should keep in mind that this patient should be treated as RHD negative until further evidence is known about their RHD status. Question 3, so how does weak D testing differ from standard D typing? It's really kind of a question about the method itself. Is it incubation of anti-D reagent and the RBCs at 4 degrees Celsius for 15 to 30 minutes, incubation at 37 degrees Celsius for 15 to 30 minutes, addition of anti-IgG following incubation of anti-D, or both B and C. Not a lot of surprise here. Everybody knows their methodology quite well, with most people picking B and C, which is the correct answer. So the weak D testing involves incubation of the anti-D reagent with the RBCs at body temperature for 15 to 30 degrees, followed by addition of anti-IgG to really pull out kind of weaker anti-D reactivity that might not be seen otherwise. Question 4. So if this patient requires red blood cell transfusion, which product would be most appropriate until additional results are available? So the group A RHD negative, group B RHD negative, group O RHD positive, or group O RHD negative. Again, as a reminder, I think we have the, so I'll go through so everybody picking group O RHD negative, which is great. Not too tricky on this one. The patient fronts as an O and backs as an O, so they're group O. They're showing some RHD positivity, but we have this discrepant typing, and until it's resolved, this patient should be treated as RHD negative. So that's the correct answer there. Question 5, for elective C-section, which of the following samples would be acceptable to issue red blood cells to the operating room? So can we issue using a sample labeled with the patient name, date of birth, collected 14 days prior to OR? The same label, but with the hospital number, collected 14 days prior to OR. Same label collected within 48 hours of the procedure, or the same label with the name, hospital number, date and time of collection, the requisition identifying the phlebotomist, and collected within 72 hours before the procedure. So most everybody got this answer of labeling with the patient name, the hospital number, the date and time, phlebotomist information, and collected within 72 hours, which is the best answer. The concepts behind this one is really kind of goes back to our CSTM standards. So recipient blood samples should be labeled in the presence of the recipient with the recipient's first and last name and a unique identification number. There has to be unequivocal identification of the person drawing the blood sample that's documented, and the date and time of collection needs to be documented as well. And for patients who've been transfused red cells, or who've been pregnant within the preceding 90 days, 3 months, or if we don't have that history, then it should be collected within 96 hours of any red cell transfusion. So that's where answer D hits all those points, and so is therefore the best answer for that one. All right. Before I move on to case 3, I guess we'll just do a check-in, make sure there's no questions.
I don't see any raised hands, so if you have a question, just raise your hand or put it in the chat.
We'll move on to case 3. So we have a 24-year-old patient who's admitted with a hemoglobin of 55. Patient has no prior transfusion history, and a diagnosis of autoimmune hemolytic anemia is made, which is in part based on a positive direct Coombs test. Question 1 is, what findings would we be expecting on their pre-transfusion antibody screening? Options are a negative antibody screen with a positive autocontrol, negative antibody screen and a negative autocontrol, positive antibody screen and negative autocontrol, or both a positive antibody screen and a positive autocontrol. In terms of responses, most people answering that would be a positive antibody screen and a positive autocontrol. Few people answering about having a negative antibody screen but a positive autocontrol, and then a minority of people in between. So in terms of what we'd expect with a patient with autoimmune hemolytic anemia, so just a reminder that autoimmune hemolytic anemia is caused by antibodies that recognize antigens that are common to all RBCs. So most of the time we're expecting these antibodies, these autoantibodies, to stick to anything we throw at it. So if we mix the plasma with any RBC, it should really be agglutinating it. And so this would be kind of a fairly standard panel we'd see with an autoantibody where every cell is reactive. So pan-agglutinin with an autocontrol that's positive because that antibody is also sticking to the patient's RBCs, which is causing the autoimmune hemolytic anemia. And so in terms of the best answer would be finding a positive antibody screen reflecting that panagglutinin, and the patient positive having a positive autocontrol. Question 2, which of the following would be acceptable to guide red blood cell selection for transfusion? So our options here are using autologous adsorption. So this is a technique where we use the patient's own RBCs to remove the autoantibody from the serum before testing it. Allogeneic adsorption, where we're using someone else's red cells to remove the autoantibody before testing it. RBCs that are phenosimilar to the recipient for the clinically significant red cell antigen, so red cell, extended red cell matching, or all of the above potential answers. This one, there's a bit of variability, so a few people picking autologous adsorption only, 50-ish people picking extended phenotype matching, and the rest of people picking all of the above. So in terms of kind of concepts behind this one, all of the above is the best answer. Again, as we go through, the patient hasn't been transfused, so we don't have to be worried about using the patient's own red cells for doing some of the adsorption. We wouldn't be worried about pulling out any antibodies that wouldn't be autoantibodies using the patient's own red cells in that case. So autologous adsorption would be an option. Allogeneic adsorption would be an option as well. Allogeneic adsorption could be done kind of regardless of the transfusion history. It's probably not the most efficient way of approaching this because it's a lot more technically demanding than doing an autologous adsorption where you're just using the patient's own red cells. But it would potentially, would be an option, just not the most efficient. And then using red cells that are going to be matched to the patient will allow you to prevent exposing the patient to any antigens that that they're missing. So if a patient is big K negative, for example, you would choose RBCs to transfuse that are also big K negative. And so if the patient has an allo anti-K that we don't know about because of the autoantibody interfering with their panel, we don't have to worry about hemolysis from that anti-K because the red cells will be matched for that patient. So that's also a reasonable option. So I think all of the above would be reasonable for this patient. Hemoglobin was 55, so it kind of might raise some questions or concerns about using red cells for autologous adsorption. But in principle, all of these would be options, so D being the best answer for this one. Question 3, so 2 years after the initial diagnosis, the patient requires an emergency appendectomy. So a repeat type and screen is sent, and we're now seeing that the autoantibody is no longer present. So we're no longer detecting the autoantibody in the patient's plasma. And the antibody screening that's done at the time is negative, and the direct Coombs test is negative. So really, this autoantibody has disappeared. So which of the following is true? So phenosimilar RBCs should be selected. An eluate should be performed to assess for the presence of the autoantibody. An ABO, RHD, and cross-match compatible RBCs should be issued, or all of the above. In terms of responses here, a little bit of a split. So some people thinking phenosimilar RBC should be selected. Very few people thinking an eluate should be performed to rule out the presence of an autoantibody, so-called, I guess, a blind eluate in this case, because the direct Coombs test is negative. ABO RHD, so kind of standard matching, and then cross-match compatible, which would be just sort of standard routine practice. Most people thinking that, and then a few people thinking that all of these should be used. So in terms of kind of principles behind this, so I guess we have to go back to thinking, well, why would we use phenotype matching? So the problem with autoantibodies is that obviously they subvert our usual pre-transfusion testing, and we can't rely on the usual panel to be able to rule out antibodies because the autoantibody could potentially is going to mask all of the any underlying alloantibodies potentially. And so the strategy of using adsorptions or phenosimilar cells, as we discussed in the previous question, is really with a goal of trying to resolve that we can't trust the usual pre-transfusion testing approach. So in a case where we would have used phenotype matching, as long as that antibody is still present, then that would be reasonable. But in this case now, since the antibody's gone away, it's no longer present. It's no longer interfering with the testing that we're doing. So we really can just rely on the standard type and screen and cross-matching techniques to be able to detect the underlying alloantibodies, and there's no concern that the autoantibody is going to interfere with that. So we can just really revert back to what our standard practice would be, which would be the ABO NRH selected and then cross-match compatible RBCs. So since the autoantibody is no longer present, then standard pre-transfusion techniques are okay. It's kind of the guiding principle behind this one. So I guess that concludes the questions we had. I don't know if there's a bit of extra time. There's questions around what we've talked about, or comments on the questions. Happy to kind of open it up to people to discuss.
Yep, we have one question. So what information would an absorption provide if a patient had no history of transfusion?
Good question. So I guess with if we could be absolutely certain the patient had zero history of transfusion ever, and could, if you knew for a fact the person had no risk factors for alloimmunization, then may not provide a lot of information. But we're often not in situations where you can be 100% sure of those kind of details. So in a case of an autoantibody, the adsorptions allow you to remove the autoantibody, and removing the autoantibody then allows you to carry out your routine screening. So testing the patient's adsorbed plasma, which is now the same plasma missing the autoantibodies, and testing that against a panel of screening cells to then see if there's any other alloantibodies that are underneath. So it allows us to then trust the sort of standard screen and panel that we would do if the autoantibody wasn't there. It isn't necessary to do that if you're able to provide phenotype matched blood. They kind of are not really complementary, but they are alternatives, I guess, to as strategies of addressing an autoantibody in a patient. So you could get around the problem introduced by the autoantibody, which is the interference with the standard testing, or the how much you can trust the screen and panel and rule out underlying allos. You can do that by either just matching for all the antigens the person is negative for, and therefore not being as worried about alloantibodies, or through the use of absorptions, cleaning out the autoantibody, and then allowing yourself to do the screening for underlying alloantibodies. Does that answer the question? Like, yeah, thumbs up, great.
Yeah. Okay, next one is Melanie Takasi said that she may have missed this, but why is looking to see if there's rouleau on the slide helpful for the weak D reaction?
Yeah, it's a good question. I think I probably tried to make the question a little too complicated. I mean, the rationale behind that is that you've got someone who's got D positive testing, and so and they had D negative testing in the past. So just making sure that it's truly a D positivity, not from other reasons, not rouleau or something else interfering with it. That should have made maybe the front type a little bit more like pan-reactive as well. So because it would have been a little bit more reasonable to check for rouleau, I guess, if the forward typing was all positive, like you had A and anti-B and anti-D. Maybe would have made that a little bit more appealing of an answer for people. But I think the big point I want to drive home with that is that genotyping is really the next best step if you're concerned about a D variant for the prenatal setting.
Does anybody else have any questions? Again, raise your hand and I can unmute you, or just type it in the chat. And Melanie just added, or maybe an albumin control.
Yeah, that would be a reasonable option too. I guess if the point being you sort of want to make sure you're not attributing D reactivity or D specificity to, or D presence of D to something that's not D related, I guess is kind of it, rather than proceeding with the weak D testing. Yeah. I probably should have just put genotyping in, but I felt it might make it a little bit too obvious if I did that. So that was kind of where I was making the question a bit overly complicated for the purpose of what the question was trying to emphasize.
Okay.
Perfect. Well, I guess if there's no other questions, then we'll pause there, and I'll just thank everyone for participating in the first part of the workshop. We'll reconvene at 2 for those of you who are participating in tier 2 for those questions. And I think Tracy and I discussed it. We'll just to keep track of participants, and the links are going to follow. We'll close out this one. We'll just ask you to re-sign in at 2 p.m. for the tier 2. Anything else on your end, Tracy?
Nope, I think that's good, and you're getting some great feedback on here, so that's great. And yes, this is being recorded and will be uploaded to the ORBCoN website probably within the next week.
Great.
All
Thanks a lot.
three of them will be, yeah, all three of them will be recorded. All right.
All right.
All right.
See you later, and good afternoon to the rest of you.